So I'm going to be talking about the treatment landscape, part one. So there are actually going to be several talks when we're thinking about the treatment landscape. We have this talk today. There's a talk tomorrow by Dr. Gonorowski, as well as we have many sponsors here today from the the pharmaceutical companies that will be talking as well. So I do have some disclosures, and so just to highlight, I have participated in an advisory board for Kai Therapeutics, as well as we are a clinical trial site for Etel Pharmaco. So when we're talking about clinical trials and participating in clinical trials, I just really want to highlight it's a complex decision. And there is, a little later today, we're going to hear from the family perspective about participating in clinical trials. And these are just some questions that I think are important for you to consider if this is something that you're interested in participating in. So what are the study questions? What are they trying to determine in this clinical trial? What is the intensity of study visits? So for the families that are here that have participated in clinical trials, it takes a lot of time. And when you're thinking about that, what is the impact going to be on daily life and family life with participating in clinical trials? There's also a financial and a time burden. Now, I want you to know that if you are participating in a regulated clinical trial, in general, there is funding for you to get to the trial sites. So we have people that travel far distances to get to trial sites. If there are long visits at the trial site, then they will also cover a hotel overnight. You also get compensated for meals while you're there at those clinical trial visits. However, what isn't compensated is your time off work. As well as your time away from your day-to-day activities. And so I think participating in clinical trials is essential when we're looking at advancing the field for Duchenne muscular dystrophy, but I think you have to think about it also within the context of your family, and does it make sense at this point in time, and is this the right trial for you? And as you can speak to your care team about these clinical trials, and then you're going to be making the right decision for you, for the individual with Duchenne, and is this the right timing? When you are consenting for a clinical trial, they do talk about the potential risks as well as the potential benefits. And I'm going to talk about a few key terms for clinical trials in a couple of slides. There are different phases of clinical trials. So phase one is really looking at, is it safe? What dose should we be using? And this is in a very small group of individuals. And in general, this is with individuals who do not have Duchenne. Now, in phase two clinical trials, it is what are the side effects? What is the optimal or the best dose? What dosing should be used in the clinical trials? And these individuals have Duchenne, and they're also a small number. Phase three in general is about effectiveness. Does this work? Is it safe? There are always safety questions for all of the different phases of clinical trials. And in the phase three studies, you're comparing it with commonly used treatments. So for when we're looking in Duchenne, individuals are on corticosteroid treatment because that is our standard of care for Duchenne muscular dystrophy. And within the study, they are placebo-controlled. My next slide tells you what a placebo is. And then even after we have clinical trials and after the drugs are approved, we need to keep on learning. And there's this post-marketing surveillance because we aren't going to know about all the side effects in the clinical trials because clinical trials in general are small in numbers. So some of the key terms you'll hear about are inclusion criteria. So these are the clinical factors that must be present to participate. So in general, people have to be on a stable dose of steroids for a period of time before they can be enrolled in the clinical trial. There could be age criteria, there could be heart function criteria, there could be physical criteria, there could be genetic change criteria. So this will all be reviewed with you when you're thinking about clinical trials. Their exclusion criteria. So there are characteristics that would prevent, not present, prevent a person from participating. So sometimes if you've had one type of treatment in a different clinical trial, you may not be able to participate in the current clinical trial. Or if you're taking some medications where they could be interacting, you may not be able to participate in that clinical trial. So these are the discussions you're going to have with your clinical team as well as the clinical trial team. Randomization. So this means you don't know, the physician doesn't know, the group doesn't know which group you are going to be in, because when we're looking at those phase 3 studies, we have the treatment or the study drug group, and we have the placebo group. So that's something that looks like drug, but is not the study drug. And so you're going to be randomized into one of these groups. You will eventually find out which group you're in, but not for a long time, and definitely not while you are in that trial. Another term you hear is open label. So this is when everybody gets the study drug. So some studies are open label clinical trials, and so everyone is getting that drug. And once again, steroid equals corticosteroid equals glucocorticoid. So we're going to be talking about different disease-modifying strategies. And so I just want you to know that term. And so disease, we're talking about Duchenne. Modifying, we're trying to change the clinical characteristics of Duchenne. And strategies, is, in this specific case, we're talking about different drugs or medications to be used. So at the core, which is in the center, is reducing inflammation. And so when we think about that, that's that word, glucocorticoid, steroid, corticosteroid. That is our standard of care that we have right now in Canada. You'll see a small little blue thing underneath that talks about dissociative corticosteroids, and that's vamorolone. And we'll talk a little bit about that right now, but I also know when Dr. Ward is speaking, she's also going to be talking about vamorolone. I'm going to go through each of these different disease-modifying strategies. Today, I am not going to be talking about gene therapy or microdystrophin gene therapy. That's going to be talked about tomorrow. All right, so glucocorticoids, corticosteroids, steroids. We have our classic ones, that's deflazacort, prednisone, or prednisolone. I talked about that this morning. And then we have our dissociative corticosteroids. So that's vamorolone, and we had heard about that Health Canada has approved that, and now it's undergoing that next stage of review in Canada. When we're looking at vamorolone and prednisone, there is a, I don't think it really helps if I point at my own screen. So if you look at the picture of prednisone, which is on one side of the slide, and vamorolone, which is on the other side of the slide, you might not be able to see depending on how big your screen is, but there is a small change in the molecule. And with that small change, they were targeting changing some of the side effects that we see with corticosteroid treatment, but they were trying to maintain that anti-inflammatory and the reduction of the inflammatory signaling within the cell. However, if you're looking at the bottom of the prednisone, you'll see an extra little piece at the bottom. And this is when you're looking at hormone transactivation or hormonal transactivation. And this is what gives us many of the side effects with prednisone and deflazacort. So what they were doing here is trying to reduce some of those side effects. I'm not going to go into the difference in the side effect profiles because that is going to be talked about a little bit later. I don't have a lot of data slides, but I've put up, oh, that one? But then won't it just? Oh, okay. Well, but that only helps the people that can see that screen. So I will do my best, and if I feel like I need to point, then I will point. So this is just one slide, and this is for the 48-week trial for vamorolone. And what you can see, I will actually use it, thank you. So when you're looking at the study, they had a placebo, so we know that is a drug that looks like vamorolone but is not vamorolone. And we had the lower dose vamorolone, which is 2 milligrams per kilogram. Then we had the higher dose, which is 6 milligrams per kilogram. And when you're looking, this is one of the physical function tests. So this is standing up from laying down. So supine means laying on your back. And this is standing from laying down. And they were looking at how much time it takes. And when you're looking over the 48 weeks, oops, or not, the top one is with the higher dose of vamorolone. And so this is some of the information that was shared with Health Canada when we're looking at, does this medication help from a muscle strength standpoint? Now, on the other slide that's to the right of that, there were individuals in this trial that were on prednisone, or they were on vamorolone. And that was for the first 24 weeks. And you can see they looked relatively similar for the first 24 weeks for the benefit from muscle. And then after 24 weeks, they moved over and everybody was on that higher dose of vamorolone. And so it showed ongoing benefit if you were switching from one to another medication. So this is some of the data that has allowed vamorolone to be approved in Canada. I'm going to switch gears a bit, and I'm going to move on to muscle growth and protection. And so when we're thinking about this category of disease-modifying therapies, we want to encourage muscle growth and discourage muscle breakdown. So that is the goal of it. And there are many different ways of doing this. We can enhance the repair capabilities in the cells. We can protect muscles from breaking down. We can reduce inflammation and fibrosis, and we can induce muscle development. So these are some of the strategies within this grouping. When I'm talking about clinical trials today, I'm talking about, I'll be highlighting some of the trials that are currently ongoing. There are many different strategies that we're looking at within Duchenne that I'm not going to be covering today, and you can talk to your clinical teams about this. There are many other strategies that are preclinical, so that's before they've gone into clinical trials. So I just really want you to know that there's a lot of movement and growth in this field. Okay, so within muscle growth and protection, we have something called HDAC inhibitors, and so givinostat. Some of you might have heard about givinostat. Currently, there is a trial recruiting in Canada for individuals who use a wheelchair for mobility, and so there are sites across Canada, one in Toronto, London, Ottawa, and Vancouver. So when you see things in blue, these are trials that are currently recruiting. Also within this muscle growth and protection, we have other small molecules that are being looked at, which I'll review. So givinostat, this medication blocks an enzyme, doesn't really matter, but the enzyme is called a histone deacetylase, and it kind of has two big groupings of actions. Oops, all right. So we had heard earlier that in muscles there are fibrocytes or scar tissue, so this medication is thought to reduce that in the muscles. We've also heard that there's some fatty replacement of the muscles, so this medication is thought to reduce that. It also reduces inflammation, and so when we're thinking about steroids, steroids also reduce inflammation. The other thing it does is kind of promote muscle growth. And so it's really working through several different, it has several different downstream impacts when we're looking at inhibiting HDACs. This slide, and my pointer isn't working right now, is looking at individuals who were in the first study. So these are individuals with Duchenne who were ambulatory. And they are comparing their long-term data. So there are some individuals that have been in clinical trials for a long time, and they're now in an open label extension trial. And they're comparing it to other natural history, another natural history cohort. So individuals with Duchenne that were not on a study medication. And really what it's showing is over a longer period of time, not just for the clinical trial, that they're seeing improvement of steroid plus givinostat in looking at getting up off the ground, climbing 4 stairs, as well as prolonging ambulation. And so this is when I'm talking about some of those longer term studies, because clinical trials are shorter. For givinostat, their clinical trial was 18 months. We saw for vamorolone that trial was 48 weeks. We want to make sure that we're seeing those benefits long term. So the excellent thing is scientists are continuing to look at this to see that there is long-term benefit of these medications. So CAP 1002, this is a cell therapy manufactured from donor heart tissue. And so they take these things called cardiospheres and they give them to the individual with Duchenne. And these cardiospheres secrete or kind of release these small little exosomes. And in those exosomes, they have growth factors that promote tissue regeneration. And so through this mechanism, it's thought to reduce some of that inflammation. So we know in muscles, there's a lot, in muscles in Duchenne, there's a lot of inflammation. And it's also thought to decrease muscle degeneration and have positive effects on muscle regeneration. So there's an ongoing phase 3 study in the US. It's not currently open for enrollment. That's why it's not in a color. EDGE or EDG 5506 is another small molecule strategy. And so the goal of this medication is to protect muscle fibers from injury due to contractile stress. So in your muscles, you have your muscle fibers contracting and getting shorter. And when that's occurring, it's causing a lot of stress on the outside of the muscle or the muscle membrane. So what this molecule is trying to do is the muscles are still contracting, but they're not contracting as much. So then it's disrupting the muscle membrane less. So that is the general mechanism behind this medication. And there's a phase 2 study, so that is in Becker muscular dystrophy as well as in Duchenne muscular dystrophy that's ongoing in the US right now. Now for SAT3247, this is another small molecule and it's seeking to restore asymmetric division of stem cells or satellite cells. So in our muscles, we have stem cells and they're called satellite cells. And these stem cells differentiate, or when they're dividing, some of them make muscle cells. And so we know in Duchenne, when there's disruption of the DMD gene, that instead of, so if you're looking on the left-hand side, you'll see in a typical muscle, you have your satellite cell, and it'll either go to 2 satellite cells or a satellite cell and a muscle progenitor cell. So which is like an early muscle cell. But in Duchenne, this isn't happening. So what this smaller molecule is trying to do is actually go back, influence that stem cell to be making those muscle progenitor cells. The phase 1 study for this is completed. I'm going to jump a little bit, and that's why I've put on this, this slide. I'm going to be talking about exon skipping for right now. So we've heard from the genetic counselor today that we have DNA, and in DNA we have our DMD gene. Now it goes through this process called transcription to make messenger RNA. And so this is a copy of the gene, and then that mRNA translates to make the protein dystrophin. So we know that there's a problem in DMD where we aren't making that protein because of the genetic change we're seeing in the DMD gene. So exon skipping right now is targeting that messenger RNA to influence it to make a shorter but partially functional protein. So when we're looking at exon skipping, it is mutation specific. So you need to know what mutation you have and if that mutation, if exon skipping would work for that specific gene change. The goal is to skip a specific exon during the mRNA processing to restore the open reading frame. I have a picture in my next slide to explain that. And our goal is to produce a shorter, partially functional dystrophin protein. Once again, this is the same picture we saw earlier. We have 79 exons, and they're like puzzle pieces that are all fitting together. In this example, there's a deletion of exon 48 to 50. So if you're looking at that piece 47, doesn't fit in with piece 51. So we have our out of frame mutation. So that means we're not able to make a functional protein. So when we're thinking about exon skipping, there's a small product, we call them antisense oligonucleotides, and so they are binding to the messenger RNA, telling it when it's moving over from transcription to translation to be making that protein to just skip that piece, saying we don't need that piece. And now we have matched it up, and so exon 47 is able to read through to exon 52, and we're getting a shorter version of the protein. So that is the mechanism behind exon skipping. They are looking, right now preclinically, they're looking at other ways of doing exon skipping, including using CRISPR. You'll hear more about CRISPR tomorrow. Right now we're using these antisense oligonucleotides that are working on your messenger RNA. And you have to continually give this because we're continually making protein. And so this is not a give one time type of medication. So when we're looking at exon skipping trials, these are the ones that are currently recruiting. So I've received this, or I found this information through clinicaltrials.gov, and I've indicated location of where these studies are happening. And so currently in Canada, we have an exon 44 skipping study, and that's in Calgary and London. There's an exon 50 skipping study, that's in Calgary, Vancouver, and London. I know there are more clinical trials that are coming down the pipeline, but these are the ones right now that are currently actively recruiting. If you have a question about your genetic change and you know it, I have some printouts of what gene changes are amenable to exon skipping. So if you're wondering about that, I can give you that sheet of paper so you can match that up. And I think it's just really about talking to your care team about what clinical trials are recruiting at any specific point in time, because this is constantly changing. So bringing us back, there are many disease-modifying strategies out there. We have our classic glucocorticoids, our deflazacort and prednisone. We are soon to have access to vamorolone, that's our dissociative steroid. And then we have many different strategies that are being worked on when we're thinking about add-on medications to what we currently have clinically. All right, that's it. I guess we'll open it up to questions. And we have many experts in this room as well. So if you have questions, we have Dr. Gornorowski. I see Dr. Campbell. We have many people. So throughout the day, if you have more questions, you can speak to any one of us.
I have a question.
Mm-hmm.
My question is more like, it is quite clear when the drug is in the clinical trial, but when it's coming to market, it's a very different situation, because during the trial, it has been kind of in like a glass jar, and it's been examined in there, and it was just the perfect atmosphere that was living in. But then once it comes out of the trial, you're taking this drug and exposing it to everything. And it's not as controlled as it is during the clinical trial, and it can be quite scary. How is there like a system of like navigating this part post clinical trial to ensure that, because during the clinical trial you have so many blood works, you're so peculiarly looked after, and it's just as a parent, I feel like a little scared when the drug is coming onto the market. I guess that's what I'm just trying to say.
Yeah, so I think I hear a couple of things in your question. So you are right. In clinical trials, even when we're looking at the medication, we're looking at a very narrow definition, or not a narrow definition, a very narrow group of individuals that have Duchenne that have very specific clinical characteristics. So when medications become available, it is much broader. So we may not see the same benefits that we've seen through clinical trial because everyone is at a different stage in their condition. And I think that's when you have your teams that you're working with to be monitoring, see how your child is doing, and seeing long-term, is this a helpful medication? So I think there are some unknowns when medications come to clinical practice. Now, your other question is really about how am I going to know my child's safe if we're starting a new medication when we only have a little bit of information. I think in the clinical trials, because there is such close monitoring, what it teaches us is what we need to monitor from a safety standpoint. You're right, we won't know all of the side effects, but we'll know quite a few of the side effects, and we'll also have a good idea from a safety monitoring standpoint what we need to do. So an example would be givinostat, and that is available in the US, but through the clinical trials, we've been able to know how often do we need to do blood work? What are we looking for on blood work? Once we're over that initial phase, how often do we need to continue to be looking at those things? I think we are going to find out things about drugs once they are on the market that we didn't know. And I think we're very lucky in Canada because we have a very strong network, our professional network across the country. We have several groups that meet. So, and we meet on a regular cadence in addition to having education rounds. So I think as we're learning new things, we're going to be sharing it with our colleagues. So if we see one thing in from one patient, we have this really great communication so that we can start making sure we're paying attention for other patients when we're using medications. But it is scary. It is unknown. And your physicians will only be able to tell you what they're aware of. But I think that's where the collaboration is really important, because if you're seeing something, you should be asking, could this be because of this medication? And then that's where your team will look into that further.
I know it's complicated when there's clinical trials and that you don't do them both together because for data purposes. But in theory, I mean, a question I've got is, would exon skipping and a givinostat in parallel be of benefit to Duchenne boys and men? In theory, like just looking for the future state of where things might be going.
Yeah, so I think, just so everyone heard, we're talking about the layering on of therapies as we become more and more knowledgeable about what is helpful, what's helpful for individuals with Duchenne. So I do imagine a future where we're layering on different medications, and I think we have to be really thoughtful about that. We see this in other genetic conditions where we have one medication studied, then another medication and another medication. And so in this other genetic condition that I follow that is not a neuromuscular condition, there are now 4 approved meds. And I've seen over the years how we've been adding on these different medications for benefit. And it has been helpful for these individuals. But I think when we're looking at another space within neuromuscular, so within SMA specifically, there have been there are ongoing trials looking at adding other medications on, which I think is important because we want to make sure what we're doing is helpful, but we also want to make sure we're thinking about side effects when we're layering on these different medications. So simple answer, yes, but it's a little more complicated than that. Thank you.